Assalamu alaikum. Welcome everyone on board. Today we will just try to have some word about the rheumatological conditions which anesthetists face. My first question, Abdurrahman, that what do you think that what are the things related to rheumatology which is important for anesthetist?
Sir, in case of rheumatoid arthritis or general,
Yes, I focus on the question. This is not a good impression in the exam that you should listen to the question. Yes, if it is grossly not clear, okay, fine. But because nobody will be asking you such question, but I'm just giving you an example that rheumatological conditions means it's not only rheumatoid arthritis. Rheumatology is the conditions related to the joints. Rheumatoid arthritis is one of the disease. What other disease we anesthetists face? Like what's the most
ankylosing
common? What is the
spondylitis,
most common? What is the most common condition?
sir, joint arthritis, uh,
Osteoarthritis. Osteoarthritis
osteoarthritis.
is
Yes,
Osteoarthritis isn't is a condition related to rheumatology.
yes, sir.
Okay, so now think. So very answer is not difficult one. It's very simple things. What are the concerns now you can
Concern
say
would be
osteoarthritis, seronegative spondyloarthropathies. Okay, what else?
rheumatoid arthritis, and it could be scoliosis.
Yeah, scoliosis partly. Okay. Scoliosis practically now if you think about scoliosis, so that will involve a number of time because one part of one type of scoliosis will be congenital, but one part will be acquired because of trauma or because of some neuromuscular disease. So that is a bridging between rheumatological condition and neuromuscular condition. Okay, yes, okay. Scoliosis is one of them. What else? Anything else comes to your mind? You said actually in between this conditions related to metabolic problems. Like one of them is this gout. Okay,
Yes, sir.
so okay. So what will be the challenges in such patients for anesthetist?
So generally, we would have difficulty in positioning these patients, and
Okay.
there may be multi-systemic involvement. So mostly these patients will be uh, in geriatric group. So we will have to evaluate cardio, respiratory, pulmonary function. They
Not
may be
geriatric
taking
group. Not all patients on in geriatric group. That's a thing that it can involve a variety of conditions. Okay. Mind it, we are talking about general rheumatology, not specifically. Okay.
they may be taking some medicine, disease
Like,
modifying.
like what
Uh,
are those
like
medications?
they may be taking steroids or methotrexate or
So, so
cyclosporin
now,
gold.
so the multisystemic effects of the diseases of the medications, especially NSAIDs, you know about NSAIDs. So you can tell that NSAIDs related problems. What are those? Can you just quickly enumerate?
Then they may develop gastric ulcers. It may lead to anemia. They may have kidney failure or hypertension due to kidney damage. Uh,
Okay, okay, fair enough. So, okay, so so in this way, like you can just one will be NSAIDs, one will be, and then the specific rheumatological medications. There are two different types of medications. One of them is symptomatic relief, and one of them is disease modifying. Okay, so whatever are those medications, they have multisystemic effects. They have effects on multi-systems. Am I right?
yes.
So you should just be knowing that. Okay, so now make a little more broader. So what will be the anesthesia challenges? other than medications. So medications and their effects. You have talked one. What else?
Sir, airway problem may be
Very
there
good.
if there is
Airway
some
problem. Because of two
uh,
things, you can label two things. One of them is the temporomandible joint to for mouth opening, and the other is
and
neck,
atlantoaxial subluxation.
like a
Yes.
cervical spine. So cervical spine
So,
is creating problem, so that you are not able to have an overall ankylosing and this joint ankylosis. So whenever there is limitation in joint movement, the you cannot move the neck, you cannot open the mouth, so there will be problems related to airway. There will be problems related to positioning. There may be problems related to, like if you are not able to make the patient straight, it will be even taking difficult in monitoring, difficult in IV lines. So there will be a lot of problems which you will be facing. So then another important thing, Abdurrahman, that such patients, you are not able to assess the functional class. Like patient may be
yes.
fine, no cardiac problem, but because of knee, patient is not able to move. So then it will be a problem. Okay, because you cannot assess the functional class. So this will be another anesthetic challenge in generally in these patients. Okay, so certain procedures they will be coming for non-rheumatological surgery, and rheumatological surgery, like for example, they might have some arthroscopies, arthroplasty. Then they can come for like contracture releases. So there will be a lot of things you can have in this case in such patients, and especially if you go towards the multisystemic involvement of rheumatoid arthritis. So there will be certain things which will these patients will be prone. Okay, so maybe they are coming for C-spine surgery. Okay, if it is causing problem. So okay, let's start from rheumatoid arthritis. Okay, so rheumatoid arthritis, if someone asks you what is rheumatoid arthritis,
It's an autoimmune polysystemic arthritis. It's a chronic autoimmune disease affecting multiple systems,
multiple
mainly joints.
systems. So there are, you can say that they have both articular and extra articular involvement. So that looks good. That word will be looking good. Okay. So a lot of joints will be involved, especially the small joints more frequently. And it is involving the, you can synovial membrane. So, so then it can involve any joint. Okay, and then other than articular, they have extra articular involvement as well. Okay, so what will be the extra articular? You can label that in the cardiovascular system, respiratory system, and then another thing. Some will be because of the disease, and some will be secondary to the medications. Okay. So you should be knowing what will be the effects because of the disease itself, and what will be the problems because of the treatment. Okay. So all systems are involved, this pericardial effusion, pericarditis, cardiac tamponade. Whenever the pericardial infusion or pericarditis can occur, so cardiac tamponade can follow. Okay, myocarditis, endocarditis, valve disease, and then ultimately left ventricular failure, more chances of atherosclerosis, coronary heart disease, and when peripheral vasculate is involved, so peripheral vasculitis and Raynaud's phenomena, it's a prothrombotic state. And then restrictive lung pattern, whenever the joints are not openly moving. So if it is involving the joints of the ribs, so there will be the chest wall movement will be limited. Okay, because of this costochondral disease, and also involving of the lungs. Okay, so this one, then hematological, a number of problems will be because of bone marrow suppression, because of bleeding, because of the immunosuppressant medications patient is taking. So whenever any immunosuppressant medications are taking, it can cause bone marrow suppression, liver dysfunction, kidney dysfunction. Okay. So this will be, just for instance, just understand that anti like anti-neoplastic drugs or immunosuppressive drugs. They are shutting the mouth of our own cells. Okay. So whenever they, so as a concept, remember this thing, that our bodyguards are for the taking care of our body. If they are killing ourselves, and then we are bringing the external army, of course, it is not good. So it, because it will not be able to differentiate between the army and the normal people. So it will be killing all cells. So same is concept for anti-neoplastic medications, because neoplasm is our people who are not in our control, who have gone mad. Topic, you don't know the topic, Saifullah? So this is rheumatology. Okay. So anyways,
Correct.
so yes. So whenever we are thinking about anti-cancer medications, so same concept is coming, because it is anti-cancer medications is destroying our own body. So all the things which are related to like anabolic function or growth function will be affected. So that's why there is bone marrow suppression, there is the hair fall, there is alopecia, there is multisystemic involvement. Okay, so it's like that. By the way, rheumatoid arthritis case can come in long case as well. Usually they will be asking in table viva, and if they are asking about in the table viva, you will be telling that it's a multisystemic disease, both extra-articular and articular problems, and all the things which we have already actually in our first 5 minutes we have discussed, the main points. Then this was, by the way, I was lucky enough to have very beautiful cases with multiple problems. So whenever, this is another message, because one of time my case had a patient was rheumatoid arthritis and TB, and patient had taken anti-tuberculous medications as well as he was on rheumatoid medications. So actually it was looking difficult, but it became very easy, because now there were so many things to speak out, and so many questions for the examiner. So actually they just touched everything. So sometimes more problems, don't worry about it. If you find your patient has a lot of problems, don't worry about it. Actually that will be a blessing in disguise, because for a person like me, which who is not very good in cramming small points, I have more of conceptual study always, even today. So I focus more on the concepts rather than tiny things. So actually it became easy, because they were asking the complications or side effects of groups of medication. If they were only be asking me about anti-rheumatoid medications, maybe they are asking about each and every disease in each and every drug in detail. So sometimes it is difficult to differentiate. But if you are answering in a group, it becomes easy. So for the people who are preparing for MCQs, of course they need to know each and every side effects individually. Okay. So this is just this is a common thing which you can face. Okay. So another, so coming back to, so these are the things which are patient will be correlated. So syndromes, if it is rheumatoid arthritis, splenomegaly, and neutropenia, it is Feltis syndrome. Okay, so Sjogren syndrome is rheumatoid arthritis with dryness and dry mouth and dry eyes. So it is keratoconjunctivitis sicca. So just what you, how will you pronounce it? Sjogren syndrome or Sjogren syndrome, whatever. So you can just, and another thing, please don't try to remember each and every word. Then it will, maybe you will forget everything. Try to understand what is the main problems, main things, and which you can reproduce. Okay. So diagnosis, actually they are doing these auto antibodies scan, but not necessarily always it will be RA positive. Even if RA positive is not there, they will diagnose on the clinical side. There will be radiological changes, there will be multisystemic involvement, but they may be seronegative. Okay, so that's the thing which you should be knowing. And they do multiple antibodies, because it has some association with all other autoimmune disease. Whenever one autoimmune disease is there, it may be involvement of other autoimmune disease as well. Okay, so this is so they will be doing simple radiography of the joints, and for our extra articular or ultrasound, CT scan, MRI. Okay, so this is something new, anticyclic acetyl-generated peptide. I don't know about it. Don't waste your energy in it. And then in the treatment, there will be two different type. One will be the symptomatic treatment that I told you, from the NSAIDs, from steroids, and maybe some, now there may be some joint intra-articular injections, because it will not be written here. Now they are trying to do this platelet rich plasma as well. Can anyone tell what is the rationale of using PRP like what is the rationale of using PRPs, platelet rich plasma? Yes, anyone please?
Sir, they are platelet-rich growth factor, no?
Very good.
So
We have the growth
they
factors, the same thing which from which the
uh, they would act like increasing the thing like the platelet derived growth factor, vascular endothelial growth factors. So they would act increasing the immunity or thing like that. Is it so?
what is growth factor?
Uh,
Like basic thing to be very simple, these are the same factors which are there when the development is there. Okay, when anything is
yes, sir.
developing, so the same factors, you see, this is what it's a is a naturally acting substance capable of stimulating cell proliferation, wound healing, and occasionally cellular differentiation. Got my point? So the same, go to the basic, like from where the body was created, the same factors we are trying to awaken the cells again, so that they may go come in senses. Okay, the crazy cells, they will try to come back. That's why now the role of PRP is a lot, and maybe this question you should prepare, that what is the role of PRP. They are using it for in plastic surgery, they are using it in the orthopedic surgeries, they are using it for hair transplant, they are using it as like bridging towards the joint replacements. So there are so many roles, so you should be knowing what are the things, how they use it, how they inject it. They will like withdraw the blood, and there will be a machine which will be removing the RBCs, and the remaining mixture will be, they will process under sterile condition, they will try to re-inject. That's the concept. Okay, but it can because it will cause inflammation at that time, so maybe it can worsen the symptom for some time. So that's that's the thing. So of course this is not primarily our specialty, either from the pain medicine side, or the orthopedic surgeon or rheumatologist may be governing this thing, which candidate patients are candidates for uh, this one PRP or not. But this is something you, in a discussion, you should keep this thing in your mind, that in the symptomatic relief, even this is there, and the disease modified drugs, penicillamine and the methotrexate. Okay, so these are the medication. You should be knowing the individual mechanism of action and side effects a little bit. So anti-metabolite poison, folate poison, like it is acting on the folic acid synthesis, which is with through this protein pathway. I'm not very good at it. You should be knowing a little bit about it. Okay, so this I have association with this medication. So actually, I'm taking myself because I have HLA-B27. Okay. So I have negative spondyloarthropathies, but Alhamdulillah, I don't have any joint limitation. I have recurrent uveitis. So it's related to I have two symptoms of joints and one. So like this is a relatively safer medication. Uh, some medications are very dangerous. They create a lot of side effects, cell lines. So whenever they are doing it, you have to monitor. So generally, what you can tell that whenever they are taking any immunosuppressants or disease modifying agents, you have to monitor the cell lines. You have to monitor the renal functions, the liver functions. Okay, and taking care of you see in hydrochloroquine there is ocular toxicity. Some there also causes this neurological things. And whenever another thing, this is something I'm just sharing with you, because these things sometimes we don't see. Whenever they start any immunosuppressant, they do the test for the latent TB. Okay, so myself, a lot of, because it's endogenous in a lot of not like it's so common. So we have a lot of people from our part of world, they have latent TB. They don't know, they don't have active infection, but they can develop if there is immunosuppression or any immunity is decreased. So actually, I took 9 months prophylactic, one dose, single dose. In that situation, they start single dose isoniazid. Okay. So I took it for 9 months as a prevention, and then I started this anti-TNF. Why I'm telling you that, the same thing you should be remembering, that such patients on immunosuppressant, they can develop TB. So whenever you are doing the analysis, you should be thinking about all these things. Okay. So this is common for all, any of anti autoimmune diseases. Okay. So now, because it will be in, just a second, we bypass one thing I wanted to show you. For how will be the airway involved? So one will be the cervical spine, and you can read few things about it. They can ask you even about the anatomy. Okay, so you should be knowing a little bit, few words about the anatomy of this cervical vertebra, and then different subluxation. One is subaxial subluxation, in which the symptoms, early symptoms of nerve compression, and then and atlantoaxial subluxation. One will be worsened by neck flexion. Okay, so anterior flexion will be worsened by neck flexion, and the other posterior will be worsened by neck extension. Okay, this can come in the MCQ as well. And then vertical, it can cause very serious, because it will go up. Vertical mean it is going up. So destruction of lateral mass of C1 can lead to subluxation of odontoid pack through the foramen magnum, compression of, so it can be very serious, it can be fatal even. Okay. And then this lateral or rotatory subluxation can cause spinal nerve or vertebral artery compression. But this is mainly an MCQ, for an MCQ word, but you should just know that anterior flexion, posterior extension. So maybe you can make any mnemonic to just remember this thing. I'm very bad in radiology, so pardon me for that. This X-ray can come in the talks as well. So few words, if you can identify. Okay, and if you can just learn how to identify the space. Okay. Okay, so then ankylosing of the cervical spine, fixed flexion deformity. If your patient neck is not moving, if you move, even it can cause neurological damage. And then laryngeal involvement, there may be hoarseness to start with. You see, dyspnea, stridor, hoarseness, and rarely upper airway obstruction. Involvement of cricoarytenoid joint. So okay, so they have written about this one as well, laryngeal amyloidosis, and I don't know about it. But CT scan or X-ray may give you some idea, and you will be taking care of it because sometimes it can cause post-operative airway problems. And then TM joint. So TM joint, patient will not be open the mouth, and direct laryngoscopy cannot be done. Even glidoscope cannot be used. So only option is the fiber optic, awake fiber optic intubation. Okay. So this is something they can ask you. So actually now, like you see the assessment, preoperative assessment, and the basic theory will remain the same. You will be asking history question, examination, investigation. In the long case, in the table viva, you will say, I will assess the severity of the disease on the basis of relevant history, examination, and investigation to see the involvement of airway, to see the involvement of uh, cardiovascular system, respiratory system, hematological system, not only because of the disease process, but also because of the medication patient is taking. This word, if you just remember or make this sentence like this will be fit in any disease, almost any disease. Okay. So here you will have problem in positioning IV line. If your heart failure is there, you will be having invasive arterial blood pressure monitoring, and you can have problem in even if you want to give spinal, if you want to give any blocks, you will have problems. Okay, so if any neurological involvement is there, even peripheral nerve blocks, you have to document any preoperative neurological status. Maybe there is some numbness or some weakness, and now you give a block, and after that it is worsened, and they are putting on you. So you have to document. Okay. So this is something which you should be knowing. And whenever patient is on steroids, not only you are anticipating this Cushing-White features, which we see in the lemon on the drumstick features. Okay. And also you have to give stress dose. Okay, so there is a formula for it, that how you do it. Maybe it's written here as well. Stress dose. If they want to ask you how much, they will ask you. But to start with, you always say any patient on steroid, you might need to give the stress dose. Okay, according to the dose patient is taking and according to the surgical risk. That is a formula for it. Okay. So then if the patient has anemia, or so according to that, you will have things like that. Okay. And whatever immunosuppressants, you have to take care, you have to give extra caution in your manipulation, because if you don't take care, patient may receive some infections. So any patient with immunosuppressant, you have to take care. Not only you are, sometimes we are only taking care of occupational health for us, but you have to think about the patient itself. Okay. So airway assessment, detailed airway assessment, mouth opening and okay, mouth opening and neck movements, and then you will do the x-rays, and then you will do MRI, and then you will plan fiber optic. Okay, so this one, these are pharyngoscopic, see, just to see the cricoretinoid involvement and any problem in the like vocal cords. So in the exam, even if you are able to intubate yourself in the exam, you all will say fiber optic. Okay, so they can ask you how to do fiber optic. You should be knowing. Okay, a question for you, Abdurrahman. How much dose of local anesthetic you can use for fiber optic? Local anesthetic, or anyone wants to answer this?
Sir, I think it is 9 mg per kg, sir.
Up to 9 milligram per kg. Okay,
Up to 9. Yeah.
up to 9. So how will you calculate? Like for example, if the spray, how much is the preparation of the spray?
Sir, it can be given as a 4% or
So
4%,
how
sir, I
will
think
you,
so, the spray.
how much? Because
Sir,
here percent is there. So how will you say
yes.
that how many puffs? Because here you have to calculate with the puff. So either it is 4% or 10%. Okay.
Sir, I
So how
think
will you
20 puff is equal to, I think,
10 puff?
1 ml.
10 puff is usually 1 ml. So you will
10
say
puff.
that it can be different preparation, but usually 10 puff is equal to 1 ml. Okay. Or you can even,
Yes.
you can say that if I have any doubt, I will take it in a syringe. I will make to just to see in 1 ml how many puffs are coming. These are smart answers. Okay. So according to
Yes.
the puff, you can say that if it is 10%, so one puff is 10 milligram. Okay, because 100 milligram per ml. So similarly, if it is 4%, it's 40 milligram per ml. Why I'm explaining it to you? Because awake fiber optic, we majority of us never do. Okay, majority of us. Some people have done it. It's overstated in the books. Of course, practically we find some loopholes kept, but in the exam you have to tell like this. So one option will be nebulization with lidocaine, cocaine pledgets to decrease the vascularity of the nasal cavity, or xylocaine, and then gargles, and the next will be spray as you go. Usually this is the technique. But individual blocks are, you should be knowing what are the individual blocks for fiber optic.
So there are three blocks: glossopharyngeal nerve block, superior laryngeal nerve block, and transtracheal, that is also called recurrent laryngeal nerve block.
Very good. So
So
three. So you one is in the pillar, tonsillar pillar, and how to give
yes, sir.
glossopharyngeal?
Glass was, sir, 1 to 2 ml we give in the tonsillar pillar, 2% lidocaine or 4%,
So this
depend
is for
upon the.
superior.
Uh, this is for glossopharyngeal now, and
Okay, and for
superior
superior
laryngeal.
laryngeal.
For superior laryngeal now, just be below the hyoid, greater cornu of hyoid bone. At the greater cornu of hyoid bone, we inject 1 to 2 ml of 2% lidocaine,
Yes. Okay.
and
And for transtracheal, you
for
know about it. So actually, why I'm telling you, you don't need to tell to start with. You say because practically it is less invasive, so majority of people use this technique. Okay. And alongside what you can tell about enzymolysis, you can tell about this reduced secretions. Okay, anticyalagogue like glycopyrrolate, and some enzymolysis with dexmedetomidine or midazolam, but not over sedating because otherwise it can airway can collapse. So careful titrated enzymolysis alongside this one, counseling of the patient, reassurance of the patient, because cooperation of the patient is very important. Okay, so because this they can ask you, uh, and the same answer will be there wherever you want to tell. The same answer you can tell what I have told you for any fiber optic, and you should know it because in this more than 90% chances that awake fiber optic explanation will be coming. Okay, so you should know how to answer common questions. Okay, so we have discussed these things. ABGs and lung function test. Very good. For pulmonary evaluation, for any pulmonary evaluation, the same things will come. X-ray, ultrasound, CT scan, pulmonary function test like spirometric finding, ABGs, okay, and some very specific pulmonary investigation if needed. Even if there is element of whenever there is restrictive lung disease, there are chances of development of pulmonary hypertension. Pulmonary hypertension can be evaluated through an echo or more reliably through right heart cath. Of course, nobody does it. That you want to check the pulmonary hypertension, you are sending the patient to right heart. But at least you should know that what are the steps. Okay, there will be some clinical sign symptoms. You can do echo. Okay, you can do ABGs, and then you will quantify how much is the pulmonary hypertension, and you will avoid all the factors which will worsen the pulmonary hypertension. Okay, so what are those factors? Intraoperatively, what are those factors?
sir, those are hypoxia, hypercarbia, pain, acidosis.
Sympathetic, all
Yes, sir.
what I say, my best friends. So you will take care of
Yes,
my best friends. Sympathetic
yes.
stimulation, hypercarbia, acidosis, they will. Okay. So you know that's how I hope you understand that if you understand the basic conduct of anesthesia, believe me, the life will become very easy. Okay, because same things will come whatever explanation you are telling. Okay, so if you have doubt that blood pressure can fall down on induction, say I will try to have awake arterial. If you want to have the fluid status, you can tell, if possible I will monitor cardiac output monitoring. If you have you can say about urine output. If you have doubt that there will be delayed in neuromuscular blocking effects, you can say I will monitor the neuromuscular monitoring. I will do the neuromuscular monitoring. If you in all patients you should have agent analyzer whenever possible. You can say, if anything you want to monitor the depth of anesthesia and you want to prevent awareness, you can say about BIS monitoring or entropy. Okay, so especially if you are doing like TIVA, so you will be saying that I have to monitor the BIS. Okay, so this is a smart answer, and same thing will be there. Believe me, the same answers are there for any case. Okay, so same is true for uh, like for analgesia. In addition to all fluid, there is no special requirement. You can give balanced salt if there is no other contraindication is there. Okay, like if there is no other requirement is there. A multimodal analgesia, you might need to give some stress dose of steroids. You might need to have like nerve blocks whenever possible, PCA, wound catheters. Of course, this is not a common thing, but you can tell that whenever possible, you can have wound catheters. You can have local infiltration. You can say about like intraoperatively, you can say that I will try to give paracetamol and SAIDs. Of course, in this scenario, maybe it worsen the situation, so you will try to avoid. And if they are deemed necessary, or if the patient already on NSAID, you will try to prevent the kidney injury. So, what are the intraoperative factors for prevention of kidneys? You should always remember, I will maintain the perfusion, I will maintain the perfusion pressures, I will maintain the volume status, I will make sure there is adequate 1 ml per kg per hour urine output. That's it. Is it difficult? Just tell me. And same thing is there. You have to maintain the euvolemia. You have to maintain the blood pressure should not be less than 80 millimeter mercury for significant period of time, because it will cause renal hyperperfusion and renal autoregulation will be lost. So this is a smart answer. Am I right? Agreed or not agreed?
Yes, sir.
Okay. So these are important points about rheumatoid arthritis. Let's have a look if we have something else. The same things are there. Okay. That's how you will be cramming, sorry, you will just scanning the articles. You will find the same thing, nothing difficult. Okay. And I don't think so. You will find anything extra. Almost same things will be there. So I hope this is enough for this topic. Okay. And actually, this is a source, a very nice source of articles. So we will have few words from here as well. Uh, gout, gout, two, three medications are extra. One of them is colchicine. One of them is allopurinol. So I don't remember the mechanism. I think one is xanthine oxidase something. So I think you should read few words about it. What is the mechanism of action of, remember one thing, pharmacology, minimum pharmacology. What is the Kabila? What is the type? Like, what is the basic group of the medication? What is the mechanism of action? What is the common side effects which are relevant to anesthetist? If even you don't know too much details, if you know these things, that's more than enough. The side effects relevant to anesthesia. I don't remember if they have any relevant side effects of these uh, this one and gout and anti-gout medications. Just do have a look if they have any um, side effects related to anesthesia. I don't remember, but you should be doing about it. Another medication which they are taking, the osteoarthritis people, they are taking, other than steroid and NSAIDs and topical creams, and one medication they take. What is that? Do you remember? Anyone? Very beautiful name. Palmidronate, alloduronate. Okay. So these are bisphosphonates. These are taking for osteoarthritis as well as osteoporosis. Okay. Because steroids can also cause osteoporosis. So you should have some words. I don't remember exactly the mechanism, but you should be knowing the mechanism of action of this allodronate. Okay, reduce fractures and common adverse effect, stomach inflammation, and so even sometimes we don't remember the names. So this is another medication which you should be knowing a little bit. We did not discuss about the bone fracture. So any patient taking steroids can have pathological fractures as well. So, okay. Once I download this presentation, I think um, actually this is medicine based, but you can get some loss of joint space for osteoarthritis, loss of joint space, osteophytes, sub subchondral cysts, subchondral sclerosis. Like, these are few things which you can just remember for yourself. Maybe. Okay, so uh, I think and and this is maximum they can ask you uh, with this reference. This is the presentations. This is there if you want to read some more details. You can have a look. Usually they will not ask, believe me. This is if you know this topic that much we have discussed, mm, more than enough. Ankylosing spondylitis. In ankylosing spondylitis, which extra thing you should be knowing?
Fixed flexion deformity, bamboo spine.
Bamboo spine. No, actually, classically, and how many patients it will be there. But for you, actually, it is the same ankylosing spondylitis. They can involve TM joint. They can involve the cervical spine. They can involve any joints like that. And these patients are taking immunosuppressants. So the actually ultimately one is difference is that one is seronegative because ankylosing spondylitis is seronegative spondyloarthropathy. It does not have any seropositive, like it will not have rheumatoid factor positive. Okay, so 1% of men and 0.5% of women. HLA-B27. So I am HLA-B27 positive. They have association with it. So sacroiliitis, okay, peripheral arthropathy, and that's it. Mm, Morning stiffness, psychological problems. They are taking a lot of medication with muscle relaxants. So actually, I forgot to mention because if they have spasticities, one medication I did not mention, the name is baclofen. Okay, baclofen is being used even intrathecally for contractures and everything. Okay, because at the end of the in the exam, you cannot remember each and everything. Okay, so few words about scoliosis. So what is scoliosis?
It is the abnormal lateral curvature of the spine is known as scoliosis.
Okay, so how it affects the anesthesia care?
Uh, Sir, it can have effect on anesthesia is that after the involvement of the spine, it can cause restrictive lung disease of the patient, which subsequently can cause pulmonary hypertension and right heart failure. So we
Okay,
have
so
to rule out cardiac involvement and respiratory involvement
yes, Zishan,
in the
when you
patient with.
started your takeoff, you missed a very small thing, which will which will which will improve your answer, and which the things which you are trying to explain, it will become much easier for you. You can say that scoliosis much depend on the pathophysiology, sorry, the type of scoliosis. Because if it is congenital scoliosis, it will have severe impact on the cardiorespiratory system. However, if it is acquired scoliosis, the effect may be because if it is congenital scoliosis, it has serious problem with the lung maturity. Am I right? Yes, Ishan, you are gone. Can you hear me?
Yes, sir, you are audible.
Okay, so actually that's what I was telling, that if it is congenital scoliosis, it will have serious problem in the lung development. Okay. So the rest of the things you told nicely, that it will be involvement of pulmonary function, and it will
Yes.
lead to pulmonary hypertension, restrictive lung disease pattern. Okay. And even this one like pulmonary hypertension and even heart failure.
Yes,
Okay.
like heart failure.
And then they can ask you to measure this Cobb's angle. So
Yes.
upper curvature and lowermost curvature, and then draw this one perpendicular from
Perpendicular.
here. This will be one perpendicular, this will be second perpendicular where it cuts. This angle is Cobb's angle. Okay. So as much it is, the more severe problems it will have. So whenever you are evaluating a patient, so you will evaluate, you see, if the angle is greater than 40 to 50, so it will create severe problems. So not only it will be affecting the cardiac, the pulmonary. Okay, and another very important aspect will be in scoliosis is in presence of neuromuscular disease. From where I started. When we started, I told you that neuromuscular involvement is very important thing. If these patients have neuromuscular involvement, so the things will be much worse. So the same evaluation, now you see, now it becomes so easy for us, the same cardiac evaluation, the same pulmonary evaluation. Okay, that's now you understand why when I used to tell the common things, why I every other day I repeat the same thing. How to plan the anesthesia, how to stratify the risk. So here the same thing will be coming. Believe me that there is no difference. If you understand this concept, it will become very easy. Okay. So same monitoring will come. Right now, you read it and tell me anything extra. Just tell me anything extra, you will find the same. My best friend will be there. Because this will be a surgery in a prone position. So all the concerns relate to prone position will be there. It can involve the cardiovascular or respiratory system. You can have, or you should have, because it will be a prolonged surgery. There will be hypotensive anesthesia. There may be bleeding. So you might need it's better to have arterial blood pressure, because you might need to do ABGs. Okay. So you should be taking arterial line. You will properly fix the endotracheal tube. You have to prevent the joint dislocations and joint injuries, nerve injuries, genitalias, breast tissue, like DVT prophylaxis, hypothermia prevention, all the good anesthesia care you will be telling. Okay. And then, as I think few days ago, I asked you this question, that if the tube is dislodged or patient have cardiac arrest in prone position, what will you do? This will be a question which they can ask. With reference to hypotensive anesthesia, you should be telling that you will be looking at the 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 blood pressure limits, and you will try not to go beyond 20 to 25% of the baseline. And another thing you can tell in hypotensive anesthesia, that you will try to make sure that your both kidneys and brain are nice. So if you go too low, it will affect the kidney functions. So this is thing you can easily tell. And if you have any doubt, you can have renal protection. So these things you should be knowing. Then if they are doing neuromonitoring, so neuromonitoring, all the basic concepts will come: the somatosensory evoked potential, the motor evoked potential, they will not be giving any muscle relaxant. You should have TIVA. Okay. So TIVA and TCI things you should be in your mind, that you can have propofol infusion, remifentanil infusion, fentanyl infusion, and you have to monitor through the BIS. You have to make sure that the IV line is in the foot near you, so that you are monitoring easy. Okay. And there was a very terrible wake up test they used to do. So the world is in 2025, and our examiners sometimes they are happy to ask this question. So how will you handle this question?
Sir, for
Wake
this
up.
we would say, sir, we would communicate with the surgeon that he should inform us earlier, at least 30 minutes before, so that we reduce our doses
Sadullah, you
to
are
and
missing
like
something. You are missing something. Who is the most important factor in this is test?
neuro monitoring, nerve
No, my
stimulator
dear.
monitoring.
No, my dear. No,
Patient, sir.
neuromonitor. Patient, the miskeen patient. You are bypassing the patient. You are also
No,
becoming
sir.
a dictator. You are also becoming a dictator. You are not thinking about the miskeen patient. You are only thinking about your mother-in-law, your surgeon.
No, no, sir. I was coming to the patient that
No.
I would.
First important thing, you have to inform the patient. You have to discuss with the patient. So, okay?
That should be done earlier, pre-op and pre-op, that
Yes. So,
intra-op
so
would
yeah,
happen
that's
to
what
him.
I'm telling you. That's why you directly jump to the surgeon. That's why I'm telling in the exam, these small things matter. Okay. So it will create a good impression for wake up test. You have to discuss in pre-operative evaluation that during the surgery, because of the surgical technique, we will be awaking you and you will be holding. You will be we will be giving you command that you may move your limbs, upper limbs and lower limbs. So you either you have to move your limb and you have to or you have to hold our hand tightly, and then we will make you
Yes,
sleep again. Okay. So this is and
yes,
then the word that which you were telling, that you will decrease the depth of anesthesia. You will make sure patient is still sleeping, but in it's coming in as much awake that he is able to obey the commands. Okay.
simple,
So he will be
simple plan.
moving. In modern surgery or modern anesthesia, wake up test is inna lillahi wa inna ilaihi rajiun. It's no more used. When there is neurophysiological monitoring, they are measuring the sensory work potential, motor work potential. They are monitoring everything. There is no need, but still you should be knowing. Okay. So these words, if you know, you can immediately easily tell. In this topic, another point will be there: scoliosis surgery. I'm repeating again and again: prone position, hypotensive anesthesia, all the care in
Yes,
prone position, and the
respiratory.
cardiorespiratory problem. And then another
Yes,
thing will be blood conservative
blood.
strategies. So what will be
Yes, sir.
what are the blood conservative strategies?
Sir, and blood conservation technique, those can be started from pre-op, intra-op, and post-op. In pre-op, we could save the patient's own blood if the patient's hemoglobin status allow us,
Very good.
and we can continue this strategy intra-op as well as
Sorry,
autologous blood.
Safiullah. Sorry, Safiullah. Few
Yes, sir.
words in the preoperative that may be in an active surgery, and you want to
Uh,
avoid the autologous blood transfusion. You can
yes,
over the period of 2 to 3 months
we
or
can
3 to 4 months.
yes.
Yes, you can
we can
save
we
his
can his
own
own
blood,
blood. We can
and
yes, sir.
give iron supplements. Okay.
Yes, I was coming to that. If it is elective surgery, we can give iron supplement, folic acid, we can give erythropoietin,
Yes,
and
and save the
vitamin
blood.
B12.
Okay, now come
Yes, and
the in the intraoperative the immediate preoperative period. You can do what you can do immediate preoperative period.
sir, we can do cell salvage.
No,
We
cell
can give
salvage is intraoperative. Cell salvage is intraoperative. Something else.
yes,
One
sir.
point you have to tell.
Uh,
What's that?
Tranexamic acid.
No, my dear.
Uh, uh,
Is it salvage? Is it
uh,
blood conservative strategies? This is pharmacological.
have,
You are missing something. Think
have,
about it. Can you pour
sir,
something? Pour something in the
yes,
blood?
sir. In the blood,
You
sir,
know, you
there are.
have only one bottle of Ruh Afza, and now 50 people have come. What will you do?
Sir, we would dilute, we were hypervolumic
Thank you very much.
hemodilution,
So, what is called as hemodilution? Hemodilution
hemodilution.
techniques. So, you will do, there are
Yes.
two different types of hemodilution. One is normovolemic
Uh,
hemodilution. What is? One
Normal
is Hypervolemic
One is
hemodilution. Okay.
hypervolemic.
So
Okay. Yes, sir.
according to the situation, either you can give over and above the dehydration, you can give 1 liter extra. Okay, this is one thing.
Yes,
Or you can do normovolemic in the sense that you will remove 1 pint of blood at the start, before the start of the
yes,
surgery, and you will replace it with 1:3 of crystalloid or 1:1 of colloid, and intraoperatively
yes,
you can transfuse the same blood. Okay.
yes, sir.
Then what else you can do? Not in this
Uh,
surgery, some of the surgery, wherever possible, you will try to
sir,
decrease the venous obstruction.
uh,
How you can do it?
sir, there are different methods like positions, like controlled hypotension, like
With that,
surgery technique,
Like
uh,
you will any elevation, surgical site
embellish,
elevation. Okay.
surgical. Yes, sir.
Surgical
Position,
site,
position. Yes, sir.
yes, surgical site evaluation, sorry, elevation. Because if it is, for example, mastoid surgery, whether it is functional endoscopic FES, okay, whether it is any surgery, you will just elevate the site. If it is, even if it is orthopedic surgery, one of the strategy will be tourniquet. One of the strategy will again the same thing which I am telling you, that you will limb
Yes.
elevate the limb to decrease the engorgement. Okay. So even tourniquet is also sort of that thing, because you are trying to like minimize the oozing and
Bleeding.
minimize okay. So then you
Yes.
will tell about the cell saver. So cell saver, you can tell that it's a closed system. You have two suctions, clean suctioning, and then it is filters, special care in cancer, or amniotic fluid. Okay, or fecal matter.
Yes.
So these three things,
Yes.
one of them may be contraindicated, but still you can use somehow this thing. And then what will you do? And then you will transfuse. They don't have coagulation factor. They have only
The
hemoglobin. It will
weights.
only transfuse the hematocrit. Okay. So then
Yeah.
a few other things you were telling, like tranexamic acid is one of them.
Yes,
Um,
sir.
this one,
Controlled hypotension.
yes, hypotension we have discussed, and then prevention of hypothermia, because hypothermia will create more platelet dysfunction. So you
More
will try to prevent
protection.
hypothermia. You will these are the factors, any factor which will promote uh, more bleeding. Okay, and one more thing you can say, that I will try to prevent the lethal triad. Okay, because
Lethal
lethal
threat.
triad
And
will
also,
create more and more
sir.
problems. Okay. Actually, the
Yes,
same
sir.
answer, if someone is appearing in an international exam, actually the same answer, almost same things, you can say in the Jehovah's Witness. Because in international exam,
Yes.
sometimes they are asking about this religious people who don't accept blood and blood product transfusion. They have different type of people. So a number of things you can tell in that one as well. Okay. And then you can
Yes.
give according to the thromboelastography or tag, you can
Yes.
uh, yes, I have. I also have invasion of my baby. Yes, just a
Yes,
second.
sir.
Pardon me. Sorry, please. So, uh, okay. So, even they have written here the same thing. Okay. And then this one will be, you see, something was coming in my mind. Yes. This one, this there was it was just again touching my mind again. One, there are artificial oxygen carriers. I don't remember the name. Like, this is also in the list. uh, it slipped out of my mind. Have anyone heard about it?
No, sir.
Okay, if I remember, I will tell you. So this is I think enough about it. Somatosensory work potential or motor work potential, whenever they are making no muscle relaxant, no inhalation agent, no nitrous oxide. Opioids can be given. Boluses are to be avoided. Better to use a constant infusion. Okay. And any factor which is affecting the latency or amplitude, both of them you have to avoid. And if it is target control infusion, it is better. Okay. You can give some things to avoid awareness, by like midazolam or this dexmedetomidine. Okay, and you will explain the patient about it, that you can have awareness. You will explain them. You will say that I will try to avoid, but according to the surgical requirement, you can have these problems. So this is all about um, like rheumatology and scoliosis. You can, if you go into details, you will find so many things. But the basic thing which I have discussed is the one which are required. Okay. Prone position. So Rahman has gone. Yes, Zishan, happy. Wajiha has just joined, I think now.
Yes, sir, I'm listening.
Okay, so you see the prone position things and the skin necrosis, contact dermatitis, tracheal compression, macroglossia, okay, breast injury, genitalia, compression of pinna, compression of nerves like femoral nerve, uh, brachial plexus injury, if the hands are too much overstretched. So these are the things which are there. And then if abdomen is pressed, there will be reduced CV, the reduced venous return. Okay, there will be increase in SVR, so cardiac output can be decreased. So these are the things which you should be knowing about prone position. Yes, ophthalmologic, very important is ophthalmological problem. And I have discussed so many times hypotensive anesthesia, prone position, and if the patient have baseline retinopathy, this can lead to transient or permanent blindness. Okay, and use of tranexamic acid, because tranexamic acid is also the microthrombi which are usually uh, cleared by the fibrinolytic system is blocked. So these microthrombi can block the tiny retinal vessels, and it can cause visual loss, temporary or permanent. So you have to be very careful about these things, because even if you have placed like this one, you have put a like jelly, or you have avoid the compression, even then the eyeball is hanging. So still it can create problem. Even if the patient have recent glaucoma surgery or retinal surgery, vitreous surgery, this is a sort of relative contraindication or risk versus benefit for any surgery in prone position. Okay, so this is what you have to tell. Okay, so these are the topics which are one of them is being asked. So thank you very much. Inshallah, we will continue tomorrow. Tomorrow I'm on call. I will try to take a session, inshallah. So maybe I was thinking about IENT. So we will just quickly discuss about you. It's better if you read these things. Now majority of preparation has been done. So I will try to. I'm trying to just cover the topics, which are majority of the topics are being covered by Dr. Fazal. So still, if you will have some topics to be remaining, I will try to cover as many as possible. I will the physics and equipment is like doing a big jihad. I will try, because this is something very difficult, even believe me, for me. But I will try. Just like I tried to do a very difficult thing, which was difficult thing for me. Yesterday I tried to do about pain. So similarly, I will try to do these things. Okay. We will try to have a session specifically on surgeries, and some topics are remaining. Remember one thing, uh, try to speak out, be confident. Yes, Abdur Rahman, you are asking something.
Sir, I have a off-topic question regarding in pre-op evaluation of a diabetic patient or a peripheral arterial disease patient. Is there any significance of lipid profile in our anesthesia management.
Lipid profile,
Yes,
anesthesia management. Actually, if it is
yes,
more, the patient, if taking this lipid lowering drugs, statins, they have some involvement with reference. One of them is that they have cardioprotective effect. But for anesthesia, they increase the this liver functions. They disturb the ALT, AST, myalgias, and this thing. This is what I remember. Anything else you have in mind?
Yes, sir. Sir,
yes,
can we ask in the like in long case, can we ask if a patient came with a ischemic heart disease? Can we ask in investigations lipid profile, or it's not necessary, sir?
Uh,
Mm.
you know,
That's my question.
okay. So actually, the thing is that remember one thing: there is no hard and fast rule in the exam. Okay, if you tell and don't tell the reason, then examiner will be offended. You can say that I have to look into the consideration about how good is the overall lifestyle and overall risk factors related to coronary artery disease or hypertension or any atherosclerotic disease. Okay, so lipid profile is the one by which I can look into the status of the patient. So you can tell. Am I right? If they ask why you
Mm.
want lipid profile, so you can explain in that way. Because if bad cholesterols are high and good cholesterols are low, this is a risk factor. Am I right?
Yes,
Yes,
sir.
sir.
Remember one thing, there is, I'm not telling you this, answering you this question from some of my book knowledge. This is common sense. So in the exam, if you happen to, if you need to answer any question like this, just relax and use your logic. Because if you think with your logic, majority of time your logic will be correct. Okay.
Okay, sir.
And again, these questions will not be a failure. If you tell, they will not fail you. Even if you don't tell, they will not fail you. The main things will be something else. These are just to make your answer more beautiful. If you will tell like this, it's something extra. Okay. In hypertension or diabetes or anything, you should be knowing the main microvascular and macrovascular complications. If you cover them, these will be extra. Because these patient may be taking, for example, the patient is taking beta blockers. So now in with the beta blockers, you can say that the beta blocker patient can have hyperkalemia. So in electrolytes, you can say the patient is taking beta blocker or patient is taking diuretics. So there may be some electrolyte changes. So it will cover both of them. Am I right? Even
Yes, sir.
thiazide, if the patient is taking thiazide diuretics or loop diuretic or potassium sparing diuretic, just imagine about the medication patient is taking of heart failure or ischemic heart disease. So patient might be taking digoxin. Patient might be taking this. So digoxin, what's the problem? That hypokalemia can precipitate digoxin toxicity. Okay, so you have to avoid hypokalemia. So it's like that.
Okay, sir.
Okay. Again, because my plea always is to have your very strong grip on the common things. If you know the common thing, the rest of the things become very easy. Okay. Thank you very much, all of you, for your presence. So, inshallah,
Thank you, sir.
if
Thank
not
you, sir.
possible, day after tomorrow we will do. Okay. I will try to have at the same time almost. Okay. Bye bye. Salam alaikum.
Walaikum assalam.